let's get back. We're going to go to the next chapter, chapter 21, bone marrow failure. I think that entire lecture is right in front of you. Bone marrow failure is the inability of the bone marrow to produce the blood cells. That's it. You have two images of bone marrow biopsy here. It's not aspiration. For those of you who are asking me why you need aspiration, why not aspiration, you need biopsy for the cellularity because of this. This is the way that you determine the cellularity of the bone marrow. This is hypercellular, this is hypocellular. All these pink, these are the bone part. The part in between, those are the bone marrow, the red bone marrow. Now the idea is this, that if your bone marrow is not producing what's supposed to produce, usually it's going to be characteristic of a condition we call that aplastic anemia. Now I give you a name, aplastic anemia, but I want you all to know aplastic anemia consists of many different diseases together. They have one thing in common. The bone marrow fails to produce the cells that's supposed to. That's what the common denominator of all these different type of diseases are. I think there are 50 different ones. I don't remember exactly remember because we are discovering new genetic mutations every day, and that's going to increase the number. So there are many of them. But what we all have in common is that when you look at their bone marrow, most of them are going to look like this. You're going to have hypocellularity, less than 30% of cellularity of the bone marrow. So something happens that the stem cells that are going to be in your bone marrow, they're either going to die or they're going to stop dividing. What can cause that? Majority of the cases, I would say about 70 to 75% of the cases are going to be idiopathic. What does it mean when I say idiopathic? It means I don't know. I don't know what's going to cause it. That's the fancy name. I will impress you guys. Idiopathic. So when something is idiopathic, it means that we don't know exactly what causes it. Sometimes you can see that people are going to develop, aplastic anemia. We know why. We put this patient on methotrexate, and all of a sudden, you're going to see a drop in hemoglobin, you're going to see a drop in white blood cells, you're going to see a drop in platelets. What's going on? You do bone marrow biopsy, you see the bone marrow hypocellular. You got aplastic anemia in your hand. Okay? So there's going to be many different reasons for it, but you've got to be able to go ahead and work your way out. One thing that's going to be common, listen, majority of them. I'm not saying all of them, so at the end of the lecture, don't come and argue with me. You said all of them are going to be like that. I didn't say that, okay? He's going to come with notes, underwriting down there, the asterisk, that small print that. I'm not saying all of them. Majority of them, all blood cells are going to drop. When I say all blood cells, it means your red blood cells are going to drop. When I say all blood cells, I mean that your white blood cells are going to drop. And when I say all cells, your platelets are going to drop. Even though those are not cells, they are cell fragments, but megakaryocytes in the bone marrow, they're going to drop in number. Okay? Now, I want to take it one step further. If I told you what aplastic anemia is, and you understood what aplastic anemia is, can anybody share some symptoms of aplastic anemia? See, without you know anything about the disease, you should be able to have some idea about the symptoms like that. If you are having low red blood cells, what are the symptoms? You're going to have fatigue, you're going to have tired, you're going to be cold, you're going to be pale. Mental tiredness, fatigue, you're not going to be able to think clearly. If you are having low platelets, what's going to be the symptom? You're going to be bleeding, you develop nosebleeds out of nowhere, you start having petechias on the surface of your skin, you're bleeding small spots under the skin. If you are going to have low white blood cells, what's going to happen to you? You're going to be prone to all sorts of infection. You're going to come down with infection after infection and after infection. You see that that's exactly what the symptoms of aplastic anemia is. Regardless what the reason is going to be, that's going to be the primary reason that you would be able to observe in these patients. Okay? All right.
Professor?
Yes.
Did you start the recording?
Did I start the recording? Yes, I did. Thank you to Tavit. Tavit told me and I did that. See? Working together always going to have a better result. Okay? Trumpism is going to take everything down to the toilet. Don't follow Trumpism. Follow the working together is a good thing. Okay. Petechia. I don't know how well you guys are able to see. These are petechias. When you're talking about purpura, it's larger spot. It's a little bit bigger spot. Petechia is smaller. It's pinpoint. It's just like a pinpoint redness. They're all due to bleeding on the skin. Small capillaries burst. And that's what you're going to have. Petechia, no platelets. Okay? Or blood clotting problems. Again, I think I have told at least half of the class, half of the students that come to my class this example. So forgive me if I'm tiring you with this example. Every round thing, every walnut is round, but not every round thing is a walnut. Okay? If you are having aplastic anemia, you're going to develop petechia. But if you have petechia, that does not mean you have aplastic anemia. Okay? Remember that. It's a symptom. We can have this to different reasons. Many of them you're going to be exposed in this class. But remember that petechia is primarily because your platelets are not working right. Okay? Stem cells, okay, pathophysiology, the idea is that something happens. The problem with the aplastic anemia is that we don't know exactly what happens. This is what we know for a fact. Aplastic anemia could be acquired. You develop it during your life. Or it could be inherited. About 80%, and I count roughly numbers in 80% because different countries are going to have different rates. About 80% of the aplastic anemias are going to be acquired. About 10 to 20% are going to be hereditary. There's a genetic mutations associated with that aplastic anemia. Okay? And out of these 80% acquired, about 70 to 80% we don't know what causes it. It's idiopathic. Okay? And the rest of them we have, okay, this person was exposed to this virus. I have seen people develop aplastic anemia after being exposed to Epstein-Barr virus. What is Epstein-Barr virus? What? Come on, I'm sure you. I can assure you that at least 80% of this class have been exposed to that virus. How can you not know about the virus that you have been exposed to? Has anybody had mono? Infectious mononucleosis? No kissing disease. Oh, I feel so sorry for you. Because most of the teenagers develop this disease because it's being transmitted through kissing. So when the teenager kisses, they pass it down in the high schools. It's good. Everybody gets mono. It's caused by the Epstein-Barr virus. I'm gonna have a little bit talk with you guys. We gotta live a little bit more. Come on. Okay. So again, everyone that gets mono, they're going to feel bad for a week. They're going to come out of it. Everything's going to go back normal. But every once in a while, I want to teach you another good word. These are the good words that are being used in medicine. You're going to encounter it a lot. Idiosyncratic. Idiosyncratic. Different responses of different people to the same thing. For instance, if you get the mono, you are able to recover from mono. If I get the mono, I'm going to develop aplastic anemia. Because my response was idiosyncratic. Because my background, genetic background is different than yours, therefore my body responded to this infection differently, overreacted, whatever is going to be like this. So that word idiosyncratic is the difference in our responses to the same stimuli. And I am telling you, and I've said that 10 years ago when I was teaching other places, I have told them the same thing, and I'm telling you, at that time I used to say 20 years. I'm telling you that within 10 years, medicine is going to change. Of course, if people like Trump get into office, nothing's going to change. But if we go the right direction, medicine is going to become idiosyncratic in a sense that if you are having, for example, chronic myelogenous leukemia, and I have chronic myelogenous leukemia, they're going to look at your genetic DNA, and they're going to look at my genetic DNA. Even though we have the same disease, that doesn't mean we have the same disease for the same reason. And they're going to treat the reason. So your treatment is going to be different than my treatment. Whenever you hear that, sometimes people did respond to medication and get better, while at the same time, same medication has no effect on other person. This is the reason. Because probably they don't have the same disease, even though we have the same name for the disease. There are different genetic mutations, they're going to respond to different drugs differently. They're idiosyncratic. Okay? Alright. Again, primary is the time that you would have the hereditary. You got different diseases. There are Fanconi anemia is one of the most common of the primary or hereditary aplastic anemias. In case of Fanconi anemia, you got a problem. So this is what the story is. You guys know that we all develop mutation in our DNA every day. Every day is happening to every one of us. But we have a system in place that is able to identify those mutations and fix it. One of the mechanisms that is going to be able to fix the DNA damage is going to be a pathway of a bunch of different proteins working together. But the name of the pathway is going to be FA pathway. FA pathway. Fanconi anemia pathway. In the case of Fanconi anemia, which is going to be hereditary type of aplastic anemia, it's genetic. I think there are 13 genes that we have discovered so far that may be involved one way or another in this disease. But we're not going to get down to that details of it. But what I want you to realize that FA pathway is responsible to fix the problems with the DNA. If you are having a DNA that is going to replicate, for example, and at the time that it replicates, you get the thymidine in here, and you get thymidine in here. This is not a match. What's going to happen here is that the enzymes that are involved in the Fanconi pathway, they are going to come, they're going to remove one of them, and they're going to replace it with the A. So you would have the right match. This is what happens to everybody's body. But if you are having a genetic mutation, those 13 genes that I'm telling you about, that's going to be coding the enzymes in that Fanconi pathway, you cannot do that. Most of them, you cannot put anything in there. So there is going to be this gap inside of the DNA, double strand. Now, so far we don't have a problem, because as long as this one is going to be intact, you're going to have an intact DNA. It's not going to fall apart. But what's going to happen if the same thing happens on this side? You got your DNA just got fragmented. Now, that's going to be a problem. Okay? People with Fanconi anemia usually by age of 40, they're going to be bone marrow failure. If they don't get bone marrow transplant, they will die. Okay? That's what's going to be Fanconi anemia. It's going to be hereditary. And I think that I was going to tell you what. There's something came to my mind. Okay. Oh, there's another thing I want to tell you about all these hereditary aplastic anemias. Fanconi anemia is going to be, this keratosis congenita is going to be another one. Schwarzman-Diamond syndrome is going to be another one. These are all three aplastic anemia, but they are hereditary. You know the genes, a bunch of genes involved in there. But they all have another thing in common. They all have two things actually in common. One, for whatever the reason is, they increase their hemoglobin F. What is the percentage of the hemoglobin F in a normal adult? Maximum 1 to 1.5%. Okay? Sometimes in these patients, it can go up to 20%. Another thing is that they all have one thing in common, and that's going to be shortening of telomeres. What are telomeres? I don't have shoelaces, but if you think about the shoelace that has that cap at the end, that plastic at the end, what happens when that cap comes off? The shoelace is going to open up, right? So at the end of the DNA chromosomes, we got these areas, they don't have any genes in them. There are telomeric regions, so they're going to have these sequences being repeated over and over. There was a time I knew actually what the sequence is. I just don't remember it. So don't take it if I'm, don't take it wrong way if I'm wrong. But it's something like, I would say, G, 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 T, A, G. Repeated 30,000 times. That's a telomere. There's no gene there, but that is going to protect the chromosomes from being damaged, because as the same way that the plastic comes off, the shoelace is going to come off, the same way it's going to happen with the DNA. Okay? These all going to have shortening of their telomeres. So the 30,000 base, and I just arbitrary number, is going to get 25,000, is going to get 5,000. As it gets smaller, it's going to go ahead and introduce more mistakes and problems with the DNA replication. You cannot control the DNA replication. And these are the things that we talked about. You can see there's another one of these viruses that quite commonly can cause aplastic anemia is parvovirus. Parvovirus B19 is going to be a virus that is going to give you inflammation of your liver. So quite often when we see about 10% to 15% of the people who develop acquired, not genetic one, not hereditary, acquired aplastic anemia, about 1 to 3 months before they developed the aplastic anemia, they had inflammation of the liver. Inflammation of the liver, what is the word, medical term for it? What is inflammation? Itis. What is liver? And put it together. Hepatitis. Okay? Hepatitis. You would see that they have hepatitis, not necessarily B or A or C, but they have the inflammation of the liver, hepatitis, and 2 months, 3 months later on, they're going to go ahead and develop aplastic anemia. Cassandra? If you acquire it, if you acquire it, the only way that you would be able to pass on any acquired mutation is that you get that mutation in the sperm or the egg. That's it. Okay? Nothing else is going to be passed on. So there are certain characteristics of, that we talked about. You already know it, about infection, bleeding, and being tired, all the symptoms of anemia. But there is also some other things that you may be able to see. You would be able to see, for example, leukoplakia. Leukoplakia is when on the surface of your tongue you're going to have these white patches. Leukoplakia. Okay? You will have these rosy cheeks. The person is going to have a very pale complexion. But all of a sudden, when it comes to the cheeks, it's going to be a lot of red rash, like on the surface of the skin, just like this kid who is having aplastic anemia. So there are different characteristics that you would be able to see. By the time that you see these characteristics, however, it's going to be the disease is going to be on the way to become very aggressive. It's just in the middle of the disease. It's not early on. Anemia, leukocytopenia, and thrombocytopenia are the primary symptoms that are going to show up first. All right. Ask a question. Serum, iron, and transferrin. I want you guys to use your logic part. We all have this little bit homunculus in our head, in our brain. This little homunculus in our brain is always telling us what is the common sense. Some people have the ability to suffocate that homunculus. Some people allow that to grow bigger and become dominant. I want you guys, for now, allow that to become dominant. What would you expect the iron serum, iron levels, and the transferrin saturation to be in aplastic anemia? Any one of them, aplastic anemia. Think about it. I want you to think about it. This is the purpose. Think about it. And when you are feeling comfortable, I want you to raise your hand and tell me. Karen? You want to do it? Do it. Karen's, which one? Serum iron decrease? Increase. So Karen says iron decrease, transferrin saturation increase. Any other opinions? Normal. If you have, Min says normal. Both of them. Anybody else? Okay. What is the problem with aplastic anemia? Bone marrow, he cannot produce the red blood cells, right? So what do you think is going to happen to the serum iron level? If you are not using that iron to make the, it's going to be increased. You're going to have increased iron level in your serum because there is nobody using that iron. What is going to happen to the percent transferrin saturation? It's going to increase because transferrin is trying to get the iron. It says, why we are not making red blood cells? Probably we don't have enough iron. Let me upgrade. Remember, I told you the fact that when you are going to be low in iron, the transferrin is going to increase. But you will be low in iron inside of the cells, right? And that's going to go ahead and induce the production of the transferrin. So the transferrin is going to be carrying more iron. So the saturation level is going to increase. So your both serum iron and the percent transferrin saturation is going to increase. Both of them. Okay? True important information would be able to help you. Question?
If you don't use the iron, will iron be stored in the...
Eventually, yes.
So that means the tissue has a higher ferritin, ferritin level where the transferrin goes down. You know what I'm saying?
Eventually, it's going to have higher ferritin levels. Okay? But in the beginning, when the disease is developing, you are going to have increased serum iron. Because serum iron is going to compensate for the lack of red blood cells. That's the way that your body responds. If you don't have enough red blood cells, it's going to think you don't have enough iron to make the hemoglobin. So it's going to increase the serum iron levels. Absorption is going to increase. Transportation is going to increase. But that's not the problem. The stem cell that is going to be receiving that is not responding. So both of those are going to increase. But ferritin, yeah, it might eventually go increase. Hemosiderin increase. But it depends on what part of the disease you are, what stage of the disease you're going to be at. So what are the treatment for the aplastic anemia? Well, we got different types of aplastic anemia. You got very severe aplastic anemia. If you have a severe aplastic anemia, the only solution that we have today is going to be bone marrow transplant. There's no other way to get out of it. Otherwise, it's going to kill you. You have severe, so you go very severe, we got severe, and the severe ones, you would be able to go ahead and do different things such as giving erythropoietin, EPO, to increase the red blood cell production. Give the patient thrombopoietin to increase the megakaryocyte production. Give the patients a colony stimulating factor. Colony stimulating factor to increase the white blood cell production. Give the patient steroids or drugs such as cyclosporine that brings your immune system down. Because remember, the reason that hematopoietic stem cell is not dividing and functioning might be due to an autoimmune response. So you give medication to reduce the immune activity of the patient, so you would be able to allow the chance for that stem cell to divide and alleviate the situation. Okay? So all those things are going to be various things. Blood transfusion is another way. If you don't have a very severe or severe, you can go in and monitor. Many of these people are not discovered having aplastic anemia. They just, they didn't feel good. They went to check the doctor, what's going on, and they found that they have aplastic anemia. Those people, you don't have to do any kind of therapy. You monitor it. If they are going really down, the hemoglobin is down, the white blood cell is down, they're bleeding, and the bone marrow is very hypocellular, then you give them blood transfusion. You give them blood transfusion in order to compensate for the lack of those cells. This is Fanconi anemia. This is what happens. The chromosomes, in the case of the Fanconi anemia, they are going to be cross-linked. Okay? Because of that cross-linking happens to all of us, we have the right enzymes to fix this cross-linking, everything is fine. But if we don't have the right enzymes that are going to be found in Fanconi, in FA pathway, this cross-linking is not going to be fixed. As time goes by, they're going to add, and it's going to cause segmentation of the chromosomes. So the chromosomes are going to be falling apart, which is going to be bad news. Again, By the age of 40, about 90% of these people are going to have bone marrow failure. And if they don't get bone marrow transplant, they will die. This keratosis congenita is going to be another type of aplastic anemia that is hereditary. To my knowledge, I'm not very updated on this one. Last time I checked, about 6 different genes that are involved. Mutations, 6 different genes. But you guys also realize that in this case, yes, aplastic anemia is going to be one of the symptoms. But you will have a lot of other symptoms as well. For example, the dystrophy of the nails. Their nails don't develop like this. That's one of the characteristics of DKS. They're going to have, as I told you, leukoplakia, the white patches on the mouth, like this guy. That's going to be leukoplakia. That's another characteristic. They will have these stains on their faces, on their, it's not a stain, but it's part of their skin. It's not something that you can wash it off. And that is going to be also a characteristic of DKS. But again, these are all genetic. And it is important to identify what is going to be the problem so you will be able to address the problems. But most of these problems are going to be only treated by prophylactic treatments. So what you are trying to do, you're trying to, if the person is low in red blood cells, give him transfusion, give him erythropoietin. If the person is low in platelets, go ahead and give him thrombopoietin in order to go or get platelet transfusion. If you are going to have white blood cell, low, go ahead and give them antibiotics so they don't develop the infection that's going to kill them. That's type of the treatment. There is no cure. For this, there is no cure. All right. So all things that we have talked about, they all have the characteristic of aplastic anemia. The only difference so far has been this. The only difference has been that in everything that we have talked about, everything drops. White blood cells, platelets, and red blood cells. Everybody understand? But we got another classes of aplastic anemia, such as the one that you are seeing, pure red cell anemia, as well as the CDEA, which we call it congenital dyserythropoietic anemia. In these conditions, the only thing that drops is red blood cell production in the bone marrow. Okay? The only thing that's going to happen is going to be different. You're going to have a normal platelets. You're going to have a normal white blood cells in both of these conditions. Okay? You're going to have the shortening of telomeres and everything happening in here. But only you're going to have it in the progenitor of the red blood cells. Not everywhere. All right? And in the case of the pure red cell anemia, you are going to have your cells become very large. When you look at the bone marrow, first of all, the bone marrow is not going to be hypercellular. It's going to be hypocellular in this case. In this case, the bone marrow is going to be hypercellular. You're going to have a lot of erythroid precursors. But none of them are going to go and make it out into the circulation. They're going to die. You're going to have ineffective erythropoiesis. So they're going to be destroyed. But again, all these are going to be genetic as well. But what's the difference between these? It's going to be the fact that you don't see a drop in white blood cells and platelets. Okay, let me see. Yeah, that's all I want to tell you about it. It can be, either one of these can be inherited or it can be acquired. Okay? And they're very rare. I mean, I think that congenital dyserythropoiesis, there is about, 500 to 600 people in the world that have this disease. It's not as common as you see it every day. Myelofibrotic anemia. Now, you will see this one. Okay? You will see it quite often, and this is the time that you need to start thinking about dacryocytes. Okay? Tree-trunk cells. And the idea is this. When I tell you that the cancer of somebody has metastasized, you understand what that means, right? When I tell you that this person had melanoma, they got a skin cancer. But unfortunately, the melanoma has metastasized. What I'm telling you is that the cancer cell got into either their blood or their lymphatic system and went someplace else in the body, such as your liver, and it starts dividing there, and it's going to interfere with the liver function. So everybody understand what that means. But in this case, what's going to happen here is the myelofibrotic anemia, those cancer cells go to the bone marrow. Okay? They're going to start dividing in the bone marrow. When you are having the cancer cells, I don't know whether or not you have encountered with this kind of situation, but if somebody has cancer that has metastasized in the bone marrow, it's very painful. It's a very painful process. You think about the fact that your bone marrow is kind of breaking. I mean, not your bone marrow. When your bone breaks, you suffer from pain, right? Everyone understand that? Now, your bone is breaking, but from inside. Because the cells are dividing and basically putting the pressure in so much cell. So the bone marrow is going to be hypercellular, but not with hematopoietic cells, with the cancer cells, with the cells that we don't want to. Okay? So what's going to happen in here? Your hematopoietic stem cells are fine. They're healthy. Everything's okay. But they're going to get kicked out of the bone marrow because cancer cells are taking their space. So they go to extramedullary spaces. They go to the spleen. They start residing in spleen. They start dividing in spleen. They go to the liver. They start dividing in the liver. I have seen extra images of patients who have had that process in the lungs. The hematopoietic stem cells start dividing in the lungs. They are producing the cells. They are producing the white blood cells. They are producing the platelets. They are producing red blood cells. But because there is not that support that is available in the bone marrow, in the other tissues, what's going to happen is that you will be able to see a lot of immature cells because of the fact that the cells have to go through a lot of narrow spaces in the spleen and the liver and things like that. You will have a lot of dacryocytes, teardrop cells. That's going to be a very important finding that we need to discover and report. You might have normal chromic cells, normal civic cells. It's not going to be hypochromic because it's anemia in this case. But you will have normal chromic cells, you will have normal size cells. Now you might be able to see target cells or something like that there, but in general they're going to be normal chromic, and you will have a lot of dacryocytes. That's a very important finding. Usually if you're finding a lot of dacryocytes, it's going to indicate extramedullary hematopoiesis, which means you are making the cells outside of the bone marrow, which is going to indicate the bone marrow space is taken. Most of the time by malignant cells, like cancer cells. Sometimes it's going to be by lipids, by fat. Fat is going to come and take over. So you're going to go in and do the bone marrow biopsy. You're going to get the bone marrow out. It's going to be all adipose tissue. It's going to be lipids. Okay? Same idea. But the bottom line is not going to be different. That there is no space for hematopoietic stem cells in the bone marrow, so that hematopoietic stem cells are going to travel to other places in the body, and they're going to start the process of extramedullary hematopoiesis. Okay? And dacryocytes and normal chromic cells are going to be one of the primary indicators of that. And of course, you can confirm it by doing bone marrow biopsy, and you would be able to determine what's going on. Anemia of chronic renal insufficiency, that's going to be the easiest one, and it's very common. I want you to know that this is very, 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 very common. And that's the time that your kidneys are not working well. Okay? If your kidneys are not functioning properly, what do you think is going to happen to your erythropoietin level? It's going to go down. You're not going to produce as much, and therefore your bone marrow is not going to respond, so you're going to develop anemia over time, right? But there are other things that's going to be happening. Because your kidney is not working right, what's going to happen to your level of urea is going to increase in your blood. Because urea is going to be disposed in the kidney. This is the job for your kidneys. And if you cannot get rid of the urea, what's going to happen? The urea is going to build up in your blood. When the urea builds up in your blood, you know what the symptom is going to be? Hyperuremia, that's true, is going to give you echinocytes. So I have told you that most of the time when we see echinocytes, 1 or 2 or 3 cells here or there, is indicative of old red blood cells. But if you know that your red blood cells, your blood, tube of blood is fresh, and you see a lot of echinocytes, you better think about uremia. You better think about the chronic renal disease anemia, because of the fact that's going to be the time that you will see the echinocytes. Normal chromic, but you will have a lot of echinocytes. Okay? All right. Let me go in and give you another 5 minutes. This place is really hot, so, but I'm going to go in and get started after 5 minutes because we're going to go to the next lecture, okay? 5 more minutes. Next lecture. So we're going to get into, again, what is the topic of our discussion overall? Anemia. We talked about anemia, underproduction, or increased loss. Now we are getting into the area that we're going to get out of underproduction into increased loss. Okay? We are losing cells. So when we are talking about that one, we are talking about hemoglobinopathies. But when we are talking about hemoglobinopathies, we're going to divide it into two groups. One group is going to be structural hemoglobinopathies. There is a problem with one or two of the chains of the hemoglobin that prevents the hemoglobin from forming. If you cannot make the hemoglobin, what's going to happen to you? You're not going to be able to make the red blood cells. Understand? The other type of hemoglobinopathy is going to be the ability to produce hemoglobin. Now, in the structural one, you do produce the hemoglobin, but you cannot make it to the end. In the one that's going to be more of a quantitative, you're not going to be able to make enough hemoglobin that's viable. If it's not viable, you're not going to be able to put it in the red blood cells. And then that's going to explain what the anemia is. In here, we're going to go ahead and talk about the structural hemoglobinopathies. Going back to what you already know. There are two chromosomes, number 16 and number 11. You got the alpha and zeta on number 16. You got beta. Is it number 16 alpha or zeta? Yeah, 16. And number 11, you're going to have the beta and delta and gamma and epsilon. That's going to be discussion today. Next time when we come on Thursday, we're going to talk about not being able to produce the hemoglobin, which is going to take us to the discussion of thalassemias. That's what the difference between thalassemia and, for example, sickle cell anemia is. Because at the bottom one, sickle cell anemia, you produce the hemoglobin. You produce the right amount of the hemoglobin. But the problem is that hemoglobin, there is a defect in it. There's a structural defect in it. When the oxygen level goes down, it's going to change its shape, it's going to polymerize, and it's going to cause all the problems associated with sickle cell anemia. Okay? In the case of thalassemia, you have another problem. Same guys are going to be involved. These are the same actors and actresses that are going to be involved in that movie. But in that movie, you're not going to be able to produce enough hemoglobin. In the structural, you produce enough hemoglobin, but there is a structural defect in that hemoglobin. So something's going to happen, the cells are going to lyse. That's a big difference. Okay? You guys already remember this one. So be aware of the chains that are going to become more apparent during the fetal age, embryonic age, fetal age, and into adulthood. So what is going to be adult hemoglobin? Can you tell me what is this going to be primarily consist of? 2 alpha and 2 beta, right? Are you going to have any fetal hemoglobin in an adult? Yes. Very small, 1 to 1.5, 2%. But you're going to have another type of, so by the way, when we are talking about HbA, hemoglobin A, some of you ask me this question. It's a good question. I hope that you always ask these kind of questions. Even though I know that it's simple, but I don't want you to feel bad. I want you to understand what's going on. What does A stand for? Adult. Okay? Now when I put HbA2, what does that A2 stand for? The second one that's most abundant in adults. Okay? That's going to be the 2 alpha to delta. It's not crazy. It's a very simple concept. Hemoglobin F. What does F stand for? Fetal. Okay? Yes, each one of them is going to consist of, this one is going to be 2 alpha and 2 gamma, but it's hemoglobin F. So be aware of those things, because I can see some of you get confused when we are discussing those things. So you can see that alpha is going to, early on in the fetal age, alpha is going to go up and it's going to stay up for the rest of the person's life. Okay? But we also see that the beta is going to be very low during the fetal age. After you are born, about, I would say within 6 months, then the Beta is going to go up, and the gamma is going to come down. It's not going to disappear, but it's going to stay low. Everybody understand that pattern, right? What I'm trying to tell you is that if you understand what I'm telling you, you're going to understand certain things. One of those things that you would understand, answer me, is that you would understand why children who have sickle cell disease, why they don't have any symptoms until they are getting at 6 months of age, 1 year old. They're going to start having the symptoms around the age of 1. Why not earlier? If the cells are in a sickle, what's the difference? The answer is up here. Because those kids, they have not developed their beta. The beta that is the defective gene is not high enough to cause problem. It will cause problem when the kid becomes 1 year of age, because at that point beta is up here and the gamma is going to be down here. And one of the treatments that we have had, we are changing. Things are changing so rapidly in medicine. I have a hard time sticking to what's going on. But what we have done so far is that we would give medication to these people. A medication that was commonly used is called hydroxyurea. Hydroxyurea would increase the expression of the gamma, and it would allow these patients to have less symptoms, because when you are having more of the gamma, you're going to have less of beta, and that would go in and offset these two. You still have symptoms, but it's going to be lessened. Okay? All right. So make sure you understand this chart. Make sure that you understand what goes up at what stage in your life. I want to tell you about the primary problems when it comes to these structural hemoglobinopathies. They are going to be genetic. And these genetic problems are acquired? No, it's going to be hereditary. You're born with it. It's being passed on from your parents. Okay? These are going to be point mutation. So remember, I hope that you guys, I think that we talked about it in the beginning of the semester, and I'm not going to do that again next semester when I teach this course. I'm not going to talk about that early part about protein synthesis and things like that, because I was told that you guys should know it. So what happens is that this is the normal sequence of a DNA for one of these alpha or beta hemoglobin, whatever. That's not important. But majority of the problem associated with this hemoglobinopathy, structural hemoglobinopathies, are going to be due to point mutation. Point mutation for different reasons. It happens for different reasons. I can explain to you, but it's really not the scope of this class for me to tell you why point mutations are going to happen. It's going to depend on what these bases are, and depending on what bases are, you can have different reasons. But the bottom line is not going to be changed. Is that when you are having a point mutation, you are going to have a single nucleotide change. In this case, for example, you are going to go ahead and have GAG, that stands for glutamic acid. If you are going to go ahead and have a point mutation, and you're going to make that GTC, you only have changed the A to T, but you are going to change the amino acids that is coding for. Remember that when you make the transcription of the DNA, you're going to get a copy of RNA of that DNA. You're going to bring that copy of RNA in the cytoplasm. You're going to translate it. When the ribosome is going to read that RNA, it's going to read it every 3 days. This is going to be glutamic acid. The next one is going to be another amino acid. The next one is going to be amino acid. In this case of point mutation is good, in a sense that you don't change the frame of that protein. Because imagine what's going to happen. Imagine what's going to happen if I go in and add another A in here. You're going to change, you're going to shift the frame of that mRNA. So every protein amino acid, if it produced from that mRNA, is going to have completely different primary structure. It's not going to be that protein anymore. Okay? However, point mutation doesn't shift it. So you're still going to have the point same amino acid polypeptide, but it's going to have one amino acid change. This is the primary problem. I would say about 90% of the structural hemoglobinopathies is due to point mutation. Okay? Point mutation. And there are a lot of them. We talk about sickle cell, but there are so many different variations that I'm not going to get into right now. When we are talking about the point mutation, and sickle cell anemia is going to be the example we're going to talk about it first, because this is the most common. And this is, let me tell you about zygosity, then we're going to talk about the sickle cell. So when we are talking about the hereditary of the sickle cell, I told you that these are not acquired. You receive the genes that are defective from your parents. But usually these genes are not going to cause they're not going to cause too much harm. They cause harm, not too much, when they are heterozygous. So this is the mother side, and this is the father side. Okay? I am going to introduce a couple of terms. Pay attention to them because it's going to make a big difference. You got to understand after I'm done what is the difference between disease and trait. Two difference terminology here. If my father has mutation on his beta hemoglobin on chromosome number 11, on the 6th amino acid, instead of having glutamic acid, he has a valine in here. Okay? My mother, on the 6th amino acid of the beta protein, is going to have valine. Okay? Both of my parents are going to have the trait. But if the sperm that gave rise to me comes from this one, it's going to have this one. And the egg is going to be this one. What's going to be my genotype? Is going to be this one. Now, I got the sickle cell disease. I am homozygous. They were heterozygous. It's going to make a big difference. Okay? Just that's what zygosity means. When you are having homozygous, you're going to have much more severe symptoms than when you are heterozygous. Okay? We are talking about mild anemia versus severe anemia. Okay? We are talking about living your life just fine, monitor. We are talking about you get transfusion every 2 months. Okay? So it's going to be making a great difference. All right, let's get into the discussion about the sickle cell then. Comment made that the hemoglobin, I told you about the names, you should be able to familiar with this. So sickle cell has been with us for a long, long time. As long as the history of humankind goes back, we have had sickle cell. I can tell you that we have had sickle cell because we even can see sickle cell in primates. Other primates do have the sickle cell as well. So the idea is that you can see there is something that I'm going to tell you what's going to happen that's going to cause the hemoglobin protein to polymerize, to become a polymer. When I say become a polymer, do you understand what that means? If this is one thing, the polymer is going to be, they all attach to each other. You're going to have a polymer on my fist, if that makes any sense. But you're going to have the same thing repeated over and over. You got a polymer. Glycogen is a polymer of glucose. Okay? Proteins are polymers of amino acids. Just trying to cross the idea, convey the idea. So what happens is going to be very simple. So what I'm going to go ahead and do, let me go ahead and turn on the lights. If I tell you something it doesn't make sense to you, I want to know. I want to know right now. I don't want to know it after the class when you come to my office. I want you to tell me that right now if it doesn't make sense. So, because it should make sense. See, people, each amino acid, I hope you realize it from your biochemistry that amino acids have different properties. Okay? We have 20 amino acids in our body. Everybody knows that, right? That you need these 20 amino acids to survive. Some of them you're going to be able to get from your diet, some of them you're going to be able to, like methionine, to make in your body. Each amino acid is going to have a property. And remember, the basic structure of all amino acids is going to be very simple. You got a carbon, that carbon is bound to a hydrogen. On one side is going to be bound to a amino group, on the other side is going to be a carboxyl group, And whatever this R group is going to be is going to give the property of this amino acid. What I mean is that if this R group has a positive charge, this amino acid is going to have a positive charge. If this R group has a negative charge, this amino acid is going to be negative charge. If this R group has no charge, this amino acid is going to be hydrophobic. It's going to hate water. If this amino acid, this side group has charge, any charge, it's going to be hydrophilic. Okay, everybody understood the scheme? So what's going to happen here is that glutamate or glutamic acid, the one that you're going to find on the 6th position on the amino acid for the beta hemoglobin, has a negative charge. Valine, which is going to be replacing that, has no charge. That's going to create a lot of problem in here. Why is it going to create a lot of problem? I tell you why. Because I already told you about the primary structure of the protein is going to affect the secondary and tertiary and quaternary structure of the proteins. So if you are having, for example, please try to go and get the idea in here. I know that my drawing is really terrible, but the point is that there's a concept I'm trying to convey to you. If, let's say this is the glutamic acid, has a negative charge, and the reason that the shape of this protein is what it is because you got a positive amino acid on this side. What does positive and negative do? They're going to attract each other, so they're going to keep this shape like this. Now this might open up and close, but it's always going to have this loop in there. Because probably this loop is going to fit someplace in an enzyme, is going to allow this protein to do what it's supposed to do. Okay? Now when you are replacing this negative charge with valine, when you remove the glutamic acid because of that point mutation, and you put valine in here, you're not going to have any more charge. Is this shape going to be maintained? No. It's not going to be maintained. I'll tell you why. That attraction and negative positive disappeared. That's not there anymore. But there is something else there. Valine is hydrophobic now. Doesn't want water. Now, if it's going to stay like this, it's going to be exposed to water. It doesn't want it. Okay? So what's going to be able to do is going to change the shape of this. So this is going to become something like this. So the valine is going to be in here, hidden deep into the molecule. Stay away from the water. The same way that the phospholipid, the non-polar part is going to be toward the inside of the membrane, and the polar part is going to be on the outside. Same idea is going to be presented in here. But what we are talking about in here is that I know that most of you think that everything is stationary in the body. But for example, when we are talking about hemoglobin, hemoglobin is going to have two stages. One is going to be, not stages, but status, I should say. We call it relaxed and tense. So if you were small enough to see a hemoglobin molecule with your eyes, it would go like this. Tense and relaxed. Tense and relaxed. It will not be just like this. Dormant and stationary. So what happens is that when you are going to go ahead and change this kind of property of the amino acids, you are going to interfere with the process of tense and relaxed. You're going to put the position of the hemoglobin that's going to be a shape that it should not be as often. One of the most important things about this one is going to be oxygen tension in the blood. PO2 of the blood. If it's decreased, it's going to exacerbate this situation. If you are having sickle cell trait, if you go below 40% PO2, you have your cells sickle. And I will tell you why in a second. If you are having sickle cell disease, 80% goes down, you're going to sickle. Okay? But 80% down, I mean, where are we going to get 80% down in PO2 in our body? I mean, that's not going to happen, right? Can anybody think of a place that you're gonna have less than 40% or less than 80% partial pressure of oxygen in your body? High altitude is one place, yeah. So people who have sickle cell, they should not travel in an airplane that is not pressurized. They should not go live in places with high elevation. That's true. But in your body, is there a place that you have a low partial pressure of oxygen? At the tissue level. So people who are having sickle cell, they should not do heavy exercise. They cannot run a marathon. They cannot do a lot of exercises, because when you're exercising, what your muscle is doing is using the oxygen. What's going to happen to the PO2 level? It's going to go down at the level of the tissue. You're going to incur sickling of the cells. Now the question is why they are going to go ahead and have that sickle shape. And the answer is also simple. Because of this baleen, now I'm going to change my shape for a second here to make a point again. You got this baleen in here. Baleen is hydrophobic. This is an aqueous environment. There is water everywhere. So what's going to happen here? This baleen is trying to run away. Okay? It tries to run away. Where is it going to run away? What's going to be closest to it? Another hemoglobin molecule. And that hemoglobin molecule, if it has the same situation, is going to create a pocket that's going to allow that non-polar valine to get stuck in this cavity, in this pocket. And this one is going to have a valine, and it's going to find another spot for the next hemoglobin molecule. And that's what's going to be causing the polymerization of the hemoglobin S and give you the sickling of the red blood cell. Okay? Now when we have talked, you have already looked at hemoglobin C, right? Hemoglobin C is the same story. The only difference is that instead of having valine there, you got lysine there. Now valine was 0 charge, it's a hydrophobic. You know what lysine is? Lysine has a positive charge. Glutamic acid, the original one, has a negative charge. Lysine is going to have a positive charge. Same story is going to happen in a different shape, but the same underlying story is going to be valid. In that case, you're not going to make crystals the way that you do it in the sickle cell. You're going to make it crystals that are going to be thick and short. Thick and short. That's hemoglobin C for you. Instead of having glutamic acid, you got lysine. Now, you can have the worst thing of both worlds. How? If this was the mother side, having the, for example, sickle cell gene mutation, and down here you got the father side has the hemoglobin C mutation, all these things are going to be random. They're all going to be random. There is no way whether or not you're going to, it's up. You want to talk about luck? Here it is. It's pure chance. There is nothing else that's going to decide. Just randomness. There's always the same chance that I'm going to have my cells are going to be this one and this one. This is called hemoglobin SC. So one parent gave you the sickle cell, the other parent is going to go and give you hemoglobin C. Okay? In that case, the crystals, some of the crystals are going to try to become the sickle crystals. The other crystals are going to go in and try to become the hemoglobin C crystals because the pockets don't exactly match, so they have to go and find their own thing. So at the end, you're going to have crystals that look like protruding out of the red blood cells. They're going to look like things like this. This is the type of crystal you would be able to see hemoglobin SC. But they are all because of the changes in its charges. Okay? We got about 15 minutes. Let me see how far we are going to be able to proceed. This is the genetic hereditary pattern of the hemoglobin S. And the same thing is going to be valid for all the hemoglobins. So everybody that is going to be heterozygous is going to have the what? Disease or trait? It's going to have the trait. If you are going to be homozygous, you are going to have the disease. Now the question is that why is sickle cell anemia is so prevalent And we discussed this with other students in class before. But if this sickle cell is so prevalent, but you can see sickle cell is going to go and introduce such a weakness to the person. Survival is going to be in danger because of sickle cell anemia. So why is that there are 150 million people living on Earth today with sickle cell disease or trait? And the answer is going to be, if you are looking at this, or looking at this, if my parents were living in the area that we have malaria, my parents would be very much immune to malaria because they are heterozygous, and heterozygous are going to be very effectively repelling the malaria. So malaria, parasite is not going to be able to give you the red blood cells. Now you understand why the sickle cell didn't disappear from the population? Because whenever a gene produces a disadvantage that is going to start showing up early, is going to take the opportunity from allowing the individuals to procreate and have their own genes passed on to the next generation. So that gene should disappear unless it gives you an advantage. And this is the story about the advantage. Because the areas that you are seeing that there is going to be malaria, they're highlighted, and the areas that you're going to be able to see various hemoglobinopathies, they fall on like a pattern, they fall on top of each other. The reason that hemoglobin S, hemoglobin C was able to stay around in the human population was the fact that it provided for the heterozygous traits, it provided immunity against malaria. Malaria is going to kill you at the age of 4 and 5. Whenever you get it, you're going to die within a few months if you don't get treatment. And we didn't have treatment 60 years ago. Everything that this is because of technology and new medicine that we are having all these new treatments. We didn't have that. So what's going to happen is that sickle cell is going to kill you when you are 20 years old. It's going to buy you enough time so you would be able to have your own children. You would be able to pass on the genes. You would be able to have more heterozygous resistant to malaria. You would be able to continue lineage. So that's what the idea about these hemoglobinopathies. People, same thing is going to be valid for 6-DPD deficiency. The most common is enzymopathy. Same thing. They are going to be resistant to malaria. Same thing is going to happen, as I said, for different hemoglobinopathy, like hemoglobin C. It's going to be like hemoglobin S. Okay? So it's going to be for all those things. They're going to create an advantage that's going to mask the disadvantage, at least temporarily. So I told you about this one. Hemoglobin S is going to crystallize when there's going to be low tension of oxygen. Anything that's going to induce the low tension of the oxygen is going to cause the cells to become sickle. But the problem is that whenever you are seeing the sickles inside of the blood, you should not see too many of them if the person is not having actively a problem. Okay? But if the person goes into if the person has a disease especially, they go in these periods of what we call sickle cell crisis, which means that all of a sudden 20-30% of their red blood cells are going to sickle. So who is going to remove the sickle cells? What's going to happen to these sickle cells? What do you think is going to happen to them? If they're going to go to the spleen, they're going to get cut in the spleen because this opening in the spleen, in the fibers of the spleen, is going to be about 2 microns. The sickle cell is not going to go through. So what's going to happen is that it's going to cause the inflammation of the spleen. It's going to cause what we call splenomegaly. The spleen is going to get bigger, and it's going to cause ultimately autosplenectomy. The spleen is going to have so many infarcts. When I talk about myocardial infarction, heart attack, you can have spleen attack because these red blood cells are going to get caught inside of the blood vessels in the spleen, and anything that's going to be distal to that occlusion is going to start to die gradually. You're going to have autosplenectomy, which means your spleen is there, but it's dead. It's not doing anything. Okay? So these people are going to have large spleen. These people might have large livers because things are going to get to the liver. So you're going to have hepatomegaly, splenomegaly. Remember that most of the time, when the cells are going to sickle, if you increase the oxygen tension, they're going to reverse back to normal cells. And if you look at that, if I have this cell lower the, actually I have seen it happen under the microscope, so it's really cool. So you give a drug to these red blood cells under the microscope, and as the oxygen is removed from the system, oxygen tension goes down, it becomes sickle. You add another drug that's going to add the oxygen, they become round like a normal red blood cell. No difference, no problem. It's really interesting. So what happens is that reversible, but sometimes when they become sickle, and if they go to this spleen, they're going to be removed. They're not going to survive. It's a reversible process. That red blood cell is going to get out of the circulation. And when you think about that, anytime that sickling happens at the level of the tissue, all those sickle cells are going to be removed by the spleen. What's going to happen? What's going to be the outcome? Anemia. Red blood cells are being destroyed. Instead of living 120 days, they are being destroyed after 15 days. What's going to be the outcome? Anemia over time. Okay? Anemia. I think I covered this part pretty well. Malaria, G6 dependency, I told you about that one as well. Hemoglobin S, okay. So you're going to have hemolysis. You all understand why that's going to be. What kind of hemolysis are you going to have? Yes, but where is going to happen? Most of it is going to be extravascular hemolysis. So do you expect, if you're having extravascular hemolysis, do you expect a lot of free hemoglobin in the blood? No. Do you expect your haptoglobin to go up or down or just be normal? Normal. Think about all those things. Why they go up and down, okay? And you're going to give the answer. What do you expect the reticulocytes to be? High? How many people say high? Anybody else? I admire your courage, because he's right. It's going to be high, because we talked about that hemoglobin production is not affected. You produce the hemoglobin. There is a structural problem with the hemoglobin. That something is going to cause damage to that cell later on. So your reticulocyte, don't be surprised if you have 25%, 20% reticulocytes. Very elevated. Okay? Because you have a turnaround. A lot of them are going to die very quickly. MCV might not even change. You're going to have normal MCV. It all depends on the state of the patient, whether or not they're in a crisis or they're just having a disease or a trait. All those factors are going to play. But don't be surprised, your MCV to be normal. Your MCH might be normal. Your RDW might increase because of the fact that these crises are going to happen not on a rhythmic, time, in timely fashion. So you will have these various population of the cells that are matured or they're new. You already know that the reticulocytes are going to be bigger. I already told you that 20-25% of the reticulocytes are present. Reticulocytes are going to be present here. So you overall going to have a larger cells, but there is going to be a variation in the size. That's why your RDW is going to increase. The cell counts, leukocyte acid, these are the things that usually bone marrow studies. What does your bone marrow studies going to show you? I want to make sure everybody understands what's going on in here before we stop. You going to show you what? Cellularity. What kind of? Be more specific. Hypercellularity of what kind of cells? What would be if I give you the same question that I just gave you right now on the exam, and I put 4 different answers in here. 3 to 1, 2 to 1, 1 to 1, 1 to 2. How would you be able to assess that? Which one is going to be the right answer? Either 1 to 1 or 1 to 2. I wouldn't put those 2 answers together, but 1 to 1, because erythroid cells are going to be taking over. Marrow is going to be hypercellular, and majority of those hypercellularity is going to be due to erythrocytes in their progeny. Okay? I'm going to stop at this time, and I'm going to pick up the rest of it next week. But remember, so this is the sickle cell, so you can see what things are going to be. So these are the sickle cells. You will see target cells. You understand why you will see nucleated red blood cells? Because you have anemia. The bone marrow starts kicking out in the 2 cells. So that's quite normal too. Okay? I will pick up from this point on next time. We're going to talk about this in the laboratory, so I will tell you about that from there. Okay, that's it.